Good morning, everyone. Today, I, Shantanu Parmar, am going to present my seminar on the topic constipation and psychiatry. My moderator is Dr. Priya Tyagi. Constipation. Let's first talk about what actually is constipation. Constipation can be defined as infrequent or difficult defecation characterized by excessive straining, hard stools, the sensation of incomplete evacuation, or the passage of fewer than 3 stools per week. According to the Bristol stool form scale, there are broadly 7 types of stools. Type 1, separate hard lump, which denotes severe constipation. Type 2, lumpy and sausage-like, denoting mild constipation. Type 3, a sausage shaped with cracks on the surface, which can be considered normal. Type 4, like a smooth, soft sausage or snake, which is also normal. Type 5, soft blobs with clear-cut edges, which denotes the diet lacking fiber. Type 6, mushy consistency with ragged edges, denoting mild diarrhea. Type 7, liquid consistency with no solid pieces, severe diarrhea. There are basically two broad classifications of constipation. First, idiopathic and then secondary. The chronic idiopathic constipation has pooled global prevalence of 14%, and the secondary constipation is due to any other disease or medication. The causes of secondary constipation are hypothyroidism, electrolyte abnormalities like hypercalcemia and hypokalemia, central neurological disorders like Parkinson's disease and multiple sclerosis, peripheral neurological disorders, irritable bowel syndrome, adhesions due to previous abdominal surgeries, strictures due to inflammatory bowel disease, anorexia nervosa, pregnancy, learning disability, and medication. And now let's talk about the few medications that cause constipation. In psychiatry, we use a drug which have anticholinergic effect, the main culprits of constipation, like the antidepressants, tricyclic antidepressant, paroxetine and reboxetine, which comes under SSRIs. Normally, SSRIs are safe for constipation, but paroxetine and reboxetine are known to cause constipation. Anti-Parkinsonian drugs, older sedating antihistamines like chlorpheniramine, antipsychotics, especially clozapine. Some antihypertensive drugs like calcium channel blockers, which reduce the smooth muscle contractility, are known to cause constipation. Serotonin antagonists like ondansetron, diuretics, opioids, oral iron supplements, calcium and aluminum antacids. Now let's talk about the physiological basis of constipation. The neuro and hormonal control of the colonic peristalsis is complex interplay which imbalance causes the constipation. Serotonin produced by the enterochromaffin cells in response to gut wall distension by food or stool bolus is the major neurotransmitter of the gut peristalsis. Clozapine-induced gastrointestinal hypomotility is the most common entity of the constipation that we encounter in the psychiatry. Clozapine is associated with the highest risk of causing constipation. Patients are 3 times more likely to be constipated compared with other antipsychotics. Colonic transit time, that is the time taken by the food bolus to cross the colon, are 4 times longer than expected in the general adult population. Combination of anticholinergic, antihistaminergic, and antiserotonergic properties alongside its sedative effects and resultant sedentary behavior is responsible for clozapine-induced gastrointestinal hypomotility. Let's talk about the risk factors for developing clozapine-induced gastrointestinal hypomotility, which are increasing age, female sex, anticholinergic medication alongside with clozapine, higher clozapine dose and plasma level, hypercalcemia, gastrointestinal disease, obesity, diaphoresis, low fiber diet, poor bowel habit, dehydration, diabetes, hypothyroidism, Parkinson's disease, multiple sclerosis. Complication of constipation can be seen like hernia, hemorrhoids, uterine prolapse in female, fecal impaction, colonic obstruction, bowel ischemia, necrosis, perforation, and sepsis. Now we'll talk about the diagnostic principle. Through detailed history and examination, we should aim to determine the severity of constipation and identify any other secondary causes if present. Let's talk about the history. Bowel habits prior to the onset of constipation is very important. Stool frequency, consistency, and size. Recent changes in bowel habits which can point toward the gastrointestinal malignancy. documentation of the diet, included fluid intake and the amount of physical activity, past medical history and drug history. Examination. The examination might entirely be normal. During abdominal examination, high-pitched tinkling bowel sounds on auscultation may indicate obstruction. Distal rectal examination may be performed to identify the fully loaded, fecally loaded rectum, masses, abnormal sphincter function, and during the distal rectal examination, we ask the patient to squeeze, and we check for blood in stools of fissures or hemorrhoids. Investigation, we need to do full blood count to check for anemia or any evidence of infection, C-reactive protein, which might give us an idea about the infection, urea and electrolyte and bone profile for evidences of dehydration, hypokalemia and hypercalcemia, HbA1c to know the diabetic status of the patient. Thyroid function tests are to be done unless already performed in the last 8 weeks. If there is abdominal pain in a woman of childbearing age, we need to perform a pregnancy test. Erect and supine plain abdominal X-ray to look for signs of intestinal obstruction leading to constipation. Management. The management of constipation can be through non-pharmacological and pharmacological basis. On the non-pharmacological front, we provide dietary advice to the patient, like increasing water intake toward 2 liters per day and fiber intake 25 to 30 grams per day. Dietary fiber may be in the form of fruit, vegetable, legumes, and bran, and if possible, the patient asked to eat the fruit with the skin. Patients should also be encouraged to increase physical activity levels. Pharmacological treatment. First, we need to rationalize the use of medication that may be contributing to constipation. Switching an antidepressant or antipsychotic to treatment with a lower anticholinergic burden. Where treatment cannot be switched, we aim to use the minimum effective dose of the same drug. Following are the pharmacological agents that can be used to treat constipation. These are laxatives, secretagogues like prostaglandin E1 analogs, bubiprostone, linaclotide, and plecanatide, which are oral guanide cyclase C agonist. Prokinetic drugs like prucalopride, which is a selective 5-HT4 receptor agonist. Orlistat, a drug which is used to aid weight loss and is a derivative or natural inhibitor of pancreatic lipase, has also shown some constipation protective factor findings. Bithanicol, a cholinergic agonist, which is given the dose of 10 mg TDS. Now let's talk about the laxatives. There are basically 4 types of laxative: bulk forming laxative, osmotic laxatives, emollient laxatives, and stimulant laxatives. Now let's talk about the bulk forming laxatives. Bulk forming laxative increase fecal mass and soften the stool and stimulate a bowel motion. Examples are isabgol husk, example fibogel, and methyl cellulose. The osmotic laxatives draw water into the bowel to soften the stool, like the lactulose and polyethylene glycol. Polyethylene glycol is also known as macrogol or movicol. Emollient laxatives. Emollient laxatives are stool softeners like docusate sodium. And stimulant laxatives stimulate the muscle of the gut to increase the peristalsis like senna, bisacodyl, and sodium picosulfate. Now, as we talked about earlier about the clozapine-induced gastrointestinal hypomotility, let's talk about the management algorithm of the clozapine-induced gastrointestinal hypomotility. If the patient does not have any symptoms of acute abdominal or evidence of sepsis, we give him the non-pharmacological advice like increasing dietary fibers and water intake, and we rationalize the use of clozapine like reducing the dose and using the minimum effective dose. If alongside with the non-pharmacological advice, we have to start a low threshold of laxatives. And then we start Senna 2 tablets at night and docusate sodium. Initial dose is 100 mg TDS. And in place of docusate sodium, we can also use Movicol, which is an osmotic laxative. And then we review within 48 hours. If the patient is fine, then we have to continue the same treatment. But if the patient is still constipated, we increase the dose of sodium docusate maximum up to 500 mg. The dose of Senna is to be increased gradually in the fashion of 1 to 2 tablets every 2 days, not exceeding 30 mg in a single dose. If the patient is still constipated, we do a rectal examination to examine for impaction. If there is impaction, we use glycerin suppositories or phosphate enema. And if it is if the patient is still constipated and no evidence of infection, then we use macrogol 1 sachet twice daily. But if during any of these steps the patient develops diarrhea, we gradually reverse the steps like we have increased in the management algorithm. We stop macrogol and reduce the dose of Sena step-by session, like we increase like 1 to 2 tablets every 2 days. We have to reduce. If the patient is still constipated, we have to discuss with the medical and surgical colleagues. Let's talk about certain special consideration with clozapine. The diagnostic algorithm which we just talked about is based on the Poriro protocol. The general principles are pre-existing constipation should be managed prior to the administration of clozapine. Patients taking clozapine should be offered prophylactic laxatives, as we always heard that prevention is better than cure. Patients should be psychoeducated about this effect and are asked to report immediately if they develop constipation. Prescribing clinicians should ask about this side effect at each clinical assessment. Bulk forming laxatives are not effective in slow transit constipation like the clozapine induced gastrointestinal hypermotility and should therefore be avoided. Instead, stimulant and osmotic laxatives should be preferred. Prevention of constipation. A slow drug titration may reduce the risk of developing constipation with dose increment not exceeding 25 mg per day or 100 mg per week. Increase dietary fiber intake 20 to 25 grams per day. Increase water intake to 2 liters per day to avoid intestinal obstruction due to increased fiber intake. Daily monitoring of food and fluid chart. Regular exercise of minimum of 150 minutes per week. Use of stool chart daily for the first 4 weeks and weekly and then monthly after that. Now let's talk about the opioid induced constipation. It affects 40 to 90% of the patient on long-term opioid therapy. Osmotic laxatives and osmotic and stimulant laxative are the first line choice in the management of OIC, but we do not use lactulose because it's a non-absorbable osmotic laxative and its persistence in the gut, it gets fermented and cause bloating in the patient. So therefore, we do not prefer lactulose. Bulk forming laxatives should be avoided due to an increased risk of bowel obstruction. Pamuras are the special class of drugs which are used in treatment of the opioid-induced constipation. Peripherally acting mu opioid receptor antagonist, they inhibit the binding of the opioids in the gastrointestinal tract and thus decreasing the constipatory effect of the opioids. These are nalmefene, naloxegol, and methyl naltrexone. These are my reference. Thank you.
Next presentation we have is of Dr. Shivashi, which is of extrapyramidal side effects.
I am Sivasis Dangwal. Today my topic is extrapyramidal side effects and my moderator is Dr. Akriti Jaiswal. First, the learning objectives. The first we know about what is the pyramidal and the extrapyramidal systems of the brain. The outline the types of drug known to cause extrapyramidal side effects. Differentiate the type of EPS symptoms and summarize the treatment of EPS. These are the pyramid pathways. The corticospinal tract, anterior and the lateral one. And these are extrapyramidal. That's the rubrospinal tract, vestibulospinal tract, reticulospinal tract. Why these are called extrapyramidal? Because they don't cross from the pyramid of the medulla. So these called are extrapyramidal. And there's a difference that pyramidal originate from the cortex areas, but the extrapyramidal originate from the basal ganglia part, the midbrain, the brainstem part, basal ganglia part. These originate from there, and they have different functions from the pyramidal pathways. Although they are both motor pathways, but like rubrospinal control the fine motor control, reticulospinal tract are the two, medial and lateral. The medial one is contraction and increases the tone, and lateral one is relaxation and decrease the tone. The third is a vestibulospinal, which helps in the balance and the posture. And there's a fourth one is tectospinal, which helps in the head coordination. How the mechanism of the any motor system acts, like first the initiation of the any motor action we do, the initiation start from the cortex area. That means the fibers which are coming from the cortex and crossing the pyramid of the medulla, and these are the pyramidal tracts. These initiation and partial integration of fine skilled distal voluntary movements controlled by pyramidal tracts. But prepare for the movement, thought process, regulation of posture, that कितनी हमें ताकत लगेगी, हमारी मसल कितनी ताकत करेगी, वो these are controlled by the extrapyramidal pathways. And किसी भी मोटर एक्शन को फाइन टच देने के लिए there is a cerebellum that both the coordinated, then we do a motor action. Extrapyramidal symptoms tend to be a dose rated of the antipsychotic drugs, mainly the first generations, appear most likely with high dose of high potency first generation antipsychotics like haloperidol, are less common with other antipsychotic medications like newer antipsychotics, clozapine, olanzapine. But once present, there may be persistent. Vulnerability to EPS may be genetically determined. These are the classification of antipsychotic drugs. These are first generation, these are low potency drugs. And these are first generation but high potency like haloperidol. And these are second generation, they are new antipsychotics, clozapine, olanzapine, resiperidol. Other agent that cause EPS like antiemetics, metoclopramide, because they are centrally acting, blocking the D2 receptor in the brain, lithium, SSRI, and tricyclic antidepressants. The pathophysiology of the EPS, the mechanism of EPS thought to be due to the antagonistic binding of the D2 receptor. There are two receptors, D1 and D2. D2 is a inhibitory and D1 is excitatory. When the antipsychotic drugs block D2, there is an uncontrolled involuntary movements of the muscles like akathisia, dystonia. These are other dopamine pathways like mesolimbic pathway, mesocortical pathway, nigrostriatal pathway, tubuloinfundibular pathway, chemoreceptor trigger zone. These are the extrapyramidal symptoms. The first one is dystonia, the tardive dyskinesia, akathisia, and the pseudo-Parkinson. First, we have to talk about the dystonia. The muscle is contracted. It occurs 1 to 5 days after the drug initiation. This is an uncontrolled muscle spasm, mostly over the face, tongue, and the neck. In the neck, this is called torticollis. In the eye is rolled up. This is called oculogyric spasm. The patient may be able to swallow or speak clearly. In extreme cases, the back may arch or the jaw dislocate. Acute dystonia can be both painful and very frightening. Common in the young males. Now talk about the treatment of this. The anticholinergic drugs are the drug of choice in these cases. Can be given orally, IM or IV, depends on the patient's situation. The patient can swallow or can't swallow. The injection procyclidine 10 mg IM stat. Where severe symptoms do not respond to simpler measures, including switching to an antipsychotic with low potentiality, botulinum toxin may be effective. The second one is tardive dyskinesia. Tardive means late. It means months to years after drug initiation. There's an involuntary painless. Dystonia is a painful condition, frightening condition, but it's a painless movement of the face, upper limb, like lip smacking, twisting the tongue, protrusion of the tongue, puffing cheese, dystonia, choreothyroid, movements of the limbs. The prevalence is more common in the females, people with negative symptoms, and associated with comorbidities like dementia, mood disorder. Assessment of this, there is a scoring system called AIMS, abnormal involuntary movement scale, and the treatment is also stop anticholinergic medication. Only in this we can't give anticholinergic because in this there are extra D2 receptors are formed, and when we give anticholinergic, their dopaminergic level rises, so patient condition can deteriorate. Then we switch to an atypical antipsychotic like olanzapine and clozapine. Third one is akathisia, the restless, agitated, need to move. He can't sit in a one place. Panic. It occurs 5 to 60 days of the drug initiation. There's a restlessness and irresistible desire to move around. And the treatment is considered altering the antipsychotic regime, reduce the dose, and lower potency antipsychotic like olanzapine. Anti-akathisic agents are the first line of the beta blockers, propranolol. Second line are anticholinergic, benzotropine. And the third one is the benzodiazepines. And the fourth one is amantadine. Involuntary movement. And the fourth one is pseudo Parkinsonism, like a typical Parkinson features in this side effect. Occurs 1 to 4 weeks after drug initiation. Parkinsonism features like rigidity, the bradykinesia, tremors, features like face-like mask, the patient is stooped posture, and the prevalence is more common in elderly females, those with pre-existing neurological damage like stroke and head injury. And the treatment part, first reduce the antipsychotic dose, switch to an atypical antipsychotic, and we can use anticholinergic, have cyclidine 5 mg, but do not prescribe at night as these symptoms are not present at the night time. The majority of the patient do not require long-term anticholinergic agent. You should be review every 3 months.
Everything is not clearly or dystonia. These are the also there actually I told you that the comment the little by the
I'll just add one thing. In the starting class, that is the for school year. May have such symptoms like गर्दन अकड़ जाएगा या आंख में चली जाए तो आप immediately bypass out because there have been cases where patient को बोले कि ऐसे patient को not to be and emergency में आता है तो doctors भी सोचते हैं कि क्या है और better tell the patient के देर तक patient को बुलाकर प्रॉब्लम आउटसाइड की क्लियर है तो अगर आप बता रहे हैं डिस्प्ले हो गया तो बाकी बात और दूसरी चीज है एडवोकेसी में हम ऐसा होता है तो भी पेशेंट मूव करे कुछ हो गया लेकिन बोलेगा कि आई एम हैविंग सच दिस इज ऑब्जेक्टिव और सब्जेक्टिव फीलिंग ऑफ दिस बिकॉज़ आई सीन पेशेंट देयर नो ऑब्जेक्टिव टू